Hello. Welcome everyone to ERMP and Beyond, where the heartbeat of clinical medicine resonates with every case we explore. We invite you to embark on a journey through the intricate world of medical puzzles. Together, we'll dissect, analyze, and solve the enigma that awaits us. Today we will discuss a case of splenomegaly. Let's begin our quest for knowledge without further delay. A 50-year-old male patient from Hamera, which is located in northwest Ethiopia, where visceral leishmaniasis and malaria are endemic, presented with left upper quadrant dragging sensation of 8 months duration, which is associated with fatigue and loss of appetite. Physical examination is remarkable for pale conjunctivae and splenomegaly of 12 cm. WBC count is 400,000 per microliter, hemoglobin is 7 grams per deciliter, and the platelet count is 80,000 per microliter. The peripheral morphology smear showed different stages of precursor lineages, with predominance of mature basophilic cells and few blast cells. What is the most likely diagnosis? A. Chronic lymphocytic leukemia. B. Chronic myeloid leukemia. C. Visceral leishmaniasis. D. Tropical splenomegaly syndrome. Imagine, if you will, a patient from the northwestern highlands of Ethiopia, a region where the battle against diseases like visceral leishmaniasis and malaria is a part of daily life. Our patient has been experiencing a persistent dragging sensation in the left upper quadrant of the abdomen for 8 months, accompanied by fatigue and a loss of appetite, symptoms that are as debilitating as they are concerning. Upon examination, the pale conjunctivae whisper tales of anemia, while an enlarged spleen, stretching to 12 centimeters, hints at a deeper malaise. The laboratory findings are even more telling, with a white blood cell count soaring to an alarming 400,000 per microliter, hemoglobin levels plummeting to 7 grams per deciliter, and a platelet count that's dropped to 80,000 per microliter. A closer look at the blood smear reveals a proliferation of immature blood cells and a significant presence of mature basophilic cells, unusual findings that raise a red flag. Now, let's delve into the differential diagnosis. The combination of splenomegaly, severe anemia, thrombocytopenia, and an extremely high white blood cell count, predominantly mature basophilic cells, points us towards chronic myeloid leukemia, or CML. This hematological malignancy is characterized by an overproduction of white blood cells, particularly granulocytes, and often presents itself with symptoms like those our patient is experiencing. In a region where endemic diseases are the usual suspects, these laboratory findings might initially seem like a curveball. However, they align more with a hematological malignancy than an infectious disease. Yet, in the world of medicine, we leave no stone unturned. It is crucial to rule out co-infections, especially in areas where diseases like visceral leishmaniasis and malaria are common foes. So, what are the next steps in our quest to confirm the diagnosis? A bone marrow biopsy will allow us to assess the marrow architecture and confirm the presence of CML. Additionally, a cytogenetic analysis is essential to detect the Philadelphia chromosome, the BCR-ABL fusion gene that is pathognomonic for CML. And how do we manage this condition? Enter tyrosine kinase inhibitors, or TKIs, such as imatinib, which specifically target the BCR-ABL fusion protein. Alongside this targeted therapy, supportive care is paramount to manage dehydration, anemia and thrombocytopenia, which may include blood transfusions and intravenous fluid. Ladies and gentlemen, let's decode the complexities of chronic myeloid leukemia, with a mnemonic that's as easy to remember as your ABCs. Well, in this case, your mnemonic is called CML patients. Let's see the details. Imagine CML as a complex puzzle where each piece represents a critical aspect of the disease. C stands for clonal, highlighting the clonal nature of this myeloproliferative disorder. M reminds us of the mutation, the notorious BCR-ABL1 fusion gene, and the fact that it's a myeloproliferative disorder primarily affecting middle-aged adults. L is for leukostasis, a symptom manifesting as priapism, which is a prolonged erection of the penis that is not caused by sexual stimulation, visual changes and headaches, and L also points to lymphadenopathy. Now, let's move to P, which signifies the Philadelphia chromosome, an abnormal chromosome 22 that's a hallmark of CML. P also reminds us phase of the CML. Remember the chronic, accelerated, and blast phases. A is for anemia, a common affliction in CML, and it also reminds us of the adult age group most affected and the activated tyrosine kinase due to the BCR-ABL fusion gene. T stands for translocation, specifically chromosome 22 to chromosome 9, leading to the creation of the Philadelphia chromosome and the subsequent tyrosine kinase activation. I is indicative of the immature granulocytes and elevated white blood cell count, and the I also refers to the intensive chemotherapy required during the blastic transformation phase. E represents the elevated white blood cell count, expansion of abnormal granulocyte proliferation, and extramedullary blast proliferation seen in the blast crisis phase. And for nilotinib, a second-generation tyrosine kinase inhibitor, which is effective against imatinib-resistant variants. T is for treatment, particularly tyrosine kinase inhibitors like imatinib, which have revolutionized the management of CML. Lastly, S stands for splenomegaly, the prominent finding often seen in patients. It also signifies survival, which has dramatically improved with modern treatments like tyrosine kinase inhibitors. However, it's crucial to note that treatment-resistant or advanced phase CML patients face poorer outcomes. To encapsulate, the survival rates for ages 15 to 64 show a promising 90% 5-year survival, while those 65 and older have a 40% 5-year survival rate. This mnemonic, CML patients, is not just a memory aid but a narrative of the journey through CML, from diagnosis to treatment. It encapsulates the essence of the disease, the challenges faced, and the triumphs of modern medicine. Thank you for your attention, and I hope this mnemonic serves you well in your studies. Option A, chronic lymphocytic leukemia, is characterized by the accumulation of functionally incompetent lymphocytes and is more common in older adults. It typically presents with lymphocytosis and may involve enlargement of the lymph nodes, spleen, and liver. Symptoms can include weakness, fatigue, and frequent infections. The blood smear in CLL usually shows a predominance of mature lymphocytes, with a characteristic smudge cell appearance. However, the presence of mature basophilic cells and the extremely high white blood cell count seen in this patient are not typical for CLL. Option B, chronic myeloid leukemia, is a myeloproliferative disorder that arises from a genetic mutation leading to the uncontrolled proliferation of myeloid cells. The hallmark of CML is the Philadelphia chromosome, resulting from a translocation between chromosomes 9 and 22. Patients often present with fatigue, weight loss, and splenomegaly. The blood smear in CML typically shows increased granulocytes, including basophils, and the presence of immature myeloid cells, or blasts, which aligns with the patient's findings. Option C, visceral leishmaniasis, also known as Kala-Azar, is a parasitic disease caused by the Leishmania species and transmitted by the bite of infected sandflies. It can lead to fever, weight loss, splenomegaly, and pancytopenia, rather than extremely elevated WBC counts as seen in this patient. The diagnosis is confirmed through the detection of the parasite in bone marrow or spleen aspirates. While the patient's symptoms could suggest visceral leishmaniasis, The specific finding of mature basophilic cells and the high white blood cell count are not typical for this disease. Option D. Tropical splenomegaly syndrome, also known as hyperreactive malarial splenomegaly, is associated with chronic malaria exposure and results in massive splenomegaly and elevated levels of immunoglobulin M. Patients with tropical splenomegaly syndrome, typically present with an enlarged spleen and elevated serum IgM levels. However, the hematological findings in tropical splenomegaly syndrome do not usually include the extreme leukocytosis and presence of mature basophilic cells observed in this patient. Tropical splenomegaly is also often associated with pancytopenia rather than extremely elevated WBC counts as seen in this patient. As we conclude today's topic, I want to express my heartfelt gratitude for your participation. Your engagement is crucial, so please, subscribe to stay updated on future sessions. Your likes and comments not only enrich our case discussions, but also help us reach a broader audience through the YouTube algorithm. Thank you once again for your active involvement in today's journey of knowledge.